Okay, so that's a brief rundown of what the menopause is. We've spoken about the symptoms before. Most people think it's the hot flushes and night sweats, and that is true. Most people get these symptoms, but you can present in lots of different ways. You don't necessarily need to have these symptoms. So you can get the physical symptoms. So the poor sleep is a big one. Obviously, we've spoken about the changes to your periods. You can get more water work symptoms, more joint pains, and there's a whole host of other symptoms. So palpitations, dry skin, thinning hair, dry eyes, lots of different ways that the menopause can present. And then you've got the psychological symptoms, so anxiety, irritability, low mood, brain fog or being more forgetful. Your head feels like it's full of cotton wool, difficulty concentrating, and then lack of confidence and self-esteem. That's really quite common. And then, of course, today we will be speaking a bit more about this. So, the impact of menopause on sex. The lack of hormones can cause changes to the skin of the vagina and the vulva, and that gives you symptoms in itself: pain, itching, burning, and that can also affect your libido. And we'll be speaking more about this towards the end of the talk. Okay, so we've done a very quick refresh on what the menopause is, what the main symptoms are. Today we're focusing on contraception. So the key question here is, do women need contraception going through the menopause transition? And the answer is absolutely yes, if you are in a relationship and you do not want to get pregnant. So I have a lot of women that tell me because they are over the age of 40 or they have menopausal symptoms that they don't need contraception. But actually, that is a myth. You absolutely do need contraception. There are a high number of women getting pregnant over the age of 40 and not necessarily it being planned. So let's talk about the different options we have available. So we've got the combined hormonal contraception, um, really commonly prescribed as the tablet. But you can also have a ring and you can also have a patch. And so that's called combined because it contains both hormones, the estrogen and the progestogen. It's excellent contraception. It's really good for your periods. It's good with period pain. It regulates periods as well. It's also helpful as an alternative to HRT in the younger population. So it can help with menopausal symptoms. It can help protect your bones. It also reduces the risk of womb cancer and ovarian cancer. However, it's not something we give to absolutely everyone. So there are some sort of things that we look at in the medical history to determine if you are a candidate for this. So, for instance, if you're over the age of 50, we don't give you the combined hormonal contraception. We ask you to swap to something else. If you're a smoker or you're overweight or you've got migraines, these are various things that we look at and may be less suitable to give the combined contraception in that scenario because there's a slightly increased risk of blood clots and heart disease in those sort of parameters. Okay. So the other option is the mini pill or the progestogen only pill. So this is safe to use throughout menopause. We can give it to women who can't have the combined hormonal contraception. So women who are overweight or are smokers or have cardiovascular disease, they can still safely have the mini pill. It's very effective in women over the age of 40. It can be helpful in painful and heavy periods as well as premenstrual symptoms. And in some women, it actually gets rid of periods altogether. So it might make it a bit more difficult to figure out when you're going through the menopause if your periods have gone, but you'll still get the menopausal symptoms like hot flushes and night sweats despite taking this pill. Okay, we're going to talk about the coils now. So we've got the copper coil, which is a non-hormonal method. A lot of women really like it because some women don't like taking hormones. So with this method, it's a coil that sits in the womb and it actually prevents the sperm and the egg from meeting and therefore fertilizing the egg. And it also prevents any fertilized eggs from sticking into the womb or implanting. So that's how it works through the copper in the coil. So women with a copper coil, it lasts for 5 to 10 years, the coil, depending on the type, and you still get your periods. So it doesn't mask the menopause. You can still then tell when you're going through the menopause. So our guidelines say that any woman who has a copper coil inserted after the age of 40 can keep it in until the menopause. So we can use it for longer in that scenario. It's excellent contraception, but the main drawback to it is that it can make periods slightly more heavy and can be a bit more painful as well. Okay, now onto the hormonal coil. An example being the Mirena. So I've shown you this before, but this is how big a Mirena coil is. It's really very, very small. Okay, you can see that. Very, very small. And the copper coil, very similar in size as well. That just gets fitted and sits in your womb, and it just releases hormone locally to thin the lining of the womb, and that's sort of how it works. So it's excellent. It's absolutely excellent for heavy periods. It really is. It's great for period pain, it's great for endometriosis related pain. However, most women don't get periods on the coil, well, this type of coil. And so it might mask the menopause. You won't necessarily know when your last period was. And if it's inserted after the age of 45, then you can keep it in until the menopause, which is excellent. So you can extend that use. However, if you're using the Mirena coil as part of HRT, then we really ought to have it refitted every 5 years. Okay, so not only is it great for contraception and bleeding problems and as part of HRT, but it's also good at treating abnormal thickening of the lining of the womb. So there's loads of different uses for the hormonal coil. There are lots of different brands, one of them being the Mirena coil. Okay, so let's go on to injections then. So the injections there in your arm or in your buttock every 3 months. This is a progestogen-based injection. It's great for heavy periods and painful periods because in most women it gets rid of periods altogether. It can also reduce the risk of womb cancer. We do, however, say that the upper age limit is 50 for the injection. We like you to go on to a different contraceptive after the age of 50. And one of the main drawbacks to the injection is that it can temporarily reduce bone density. So that bone density usually bounces back after you stop the injection. But if you've got significant risk factors for thin bones or osteoporosis, then we like you to be on a different type of contraception. Otherwise, we tend to review it every 2 years to make sure that this is still safe for you. Okay. Okay. Implant. Now, I'm an implant fitter myself, and they're very sort of small rods, 4 centimeters, sits just under the skin in your arm. You can feel it, but you can't see it. And it releases, again, progestogen throughout your body. Um, Again, very good contraception, lasts for 3 years. It's safe to use until the menopause. Some women don't get periods on this, or they get less frequent periods, so it can help with ovulation and period pain. And it's not associated with any significant sort of blood clot risk. Okay. Now, moving on to natural family planning. So this is a method where you're using no hormones, but you're looking at various parameters in the body, like the temperature or the cervical mucus thickness, to figure out when you're fertile in that month. And then you try to then avoid sexual intercourse to avoid pregnancy in that fertile period. The effectiveness is very much dependent on how good you are at figuring out when you're fertile. It's not the most effective method, and certainly throughout the perimenopause, ovulation is less predictable. So I would say this method is very difficult to get on top of during the perimenopause transition because of the predictability of ovulation. However, it's an option if you don't want hormones and you want it a completely natural method. But just bear in mind there is a higher failure rate with this method. Okay, and then moving on to moving on to barrier contraception, so condoms. Good sort of protection against pregnancy, but it depends on how good you are at using them. It can also protect against STIs or sexually transmitted infections. If you use a condom with lubricant, then it can be quite useful in vaginal dryness. And it's also safe to use throughout the menopause. Okay. Then you've got diaphragms and caps. So these sit over the cervix and they just stop basically sperm and egg from meeting. They're not often used, and it does depend a little bit on how good your pelvic floor is, because they can obviously move if your pelvic floor is not as strong. The other issue is as you go through the menopause, you're more likely to get urine infections and just generally infections down there. So putting things in can sometimes increase your risk of infections, but nonetheless, it is an option. Okay. So we're going to talk about emergency contraception. So this is what is available. Should you have an episode of unprotected sex, what can you do to prevent pregnancy? Well, all the options are available as with any age group. So you've got Levenel, which is it's a tablet, an oral medication, which you take ideally within 3 days of that event. Okay, you've got Ella1, again, another tablet, works slightly better than Levenel, and you can take it within 5 days of an unprotected episode of sexual intercourse. These two work by preventing your ovaries from releasing an egg. So they work by stopping ovulation. So if you've already ovulated, then they don't really work that well. So the best option for emergency contraception is actually the copper coil. You can have that put in within 5 days of an episode of unprotected sex, or within 5 days of expected ovulation. Again, I'm aware that obviously during perimenopause it becomes more difficult.
5 days within 6 months.
5 days of expected ovulation. But during the menopause, I'm aware that gets more difficult to predict. However, it is a very good form of contraception, not only as an emergency contraceptive, but obviously you can keep it in if you so wish, and it provides longer lasting contraception. Now, the way that the copper coil works is it prevents a potential fertilized egg from sticking into the womb, into the womb itself. So it prevents implantation. So some women may find that less acceptable, but that's kind of how it works. All of these options are safe to use in the menopause. Okay, so just a brief rundown then. What are the options by age? Well, all of the options are potential for you up to the age of 50. This is subject to your healthcare professional assessing your medical history and what is safest for you. But generally speaking, you can have any option. We do say we like to stop the combined hormonal contraception, which is either the pill, the patch, or the ring, and then the progestogen only injection. We like to stop that at the age of 50. So we switch you to something else because we feel that's safer. And then over the age of 50, you can have the coils. So that's the copper coil, the hormonal coil, the progestogen only pill, or I like to just call it the mini pill, and of course the barrier methods. These are all options that are safe throughout the menopause. Okay. So when can we stop contraception then? It's a really common question that I get asked. So our guidelines actually say we can stop contraception over the age of 55, even if you're still having periods. It's the chance of being fertile is very, very, very slim. And then from the age of 50 to 55, if you're not taking any hormones, then we normally say you can stop contraception a year after your last natural period. But if you are taking any hormones, then this really makes it difficult to figure out when your last natural period was. So we sort of say either continue contraception till 55, or you can have a blood test in some cases to figure out when we can stop contraception. So speak to your healthcare professional if you're interested in that. Okay, if you're under the age of 50, again, if you're not taking any hormones, then you can stop contraception 2 years after your last natural period. But if you are taking hormones, again, it's very, very difficult to figure it out. So speak to your healthcare professional to sort of figure out the next steps, or we normally say just carry on contraception until 55. And it's especially important in premature menopause, which is where your menopause, where you become menopausal under the age of 40. Well, in that scenario, there's actually a 5 to 10% chance that your ovaries can kickstart at any point. So there is a small risk of pregnancy. So we ask these women to continue contraception up until the age of 50 or 51. Okay, so that's been a whistle-stop tour through the different options of contraception, what's safe depending on age. I hope you found that useful. Now we're going to go through, the next part of the talk is about loss of sex drive or loss of libido. Okay, so it's often the case that as you go through the menopause, your libido also declines. And why is that? Well, we know that the various menopausal symptoms, your hot flushes, your night sweats, you're not sleeping well, obviously that's going to make you feel not very good in yourself. And obviously, if you don't feel great in yourself, you're tired, you're irritable, you're less likely to want to have sex. But we also know, as from a previous workshop we spoke about this as well, that the changes to your estrogen level affect the skin of the vagina and the vulva and the bladder. So you're more likely to get pain with sex and vaginal dryness. And this all can have this negative kind of impact on your sex drive. And that's only natural that you would feel that way. We also know that the loss of estrogen and the loss of testosterone, they both have a direct effect on lack of libido. However, we also know that it's not just about hormones, is it? Libido is very, very multifactorial. So stress, relationship issues, work issues, all of these things can affect your sex drive. It might be that actually as you're going through the menopause, you're more likely to have these issues. So maybe the lack of the sex drive can cause relationship issues, or the brain fog, the issues at work because of your menopausal symptoms can bring about stress. So it's very much a very close interplay between everything. Your family might be getting older, aging parents or health concerns with family members. This might be playing on your mind. Your own physical health might be declining. And of course, there are various medications that can affect libido, especially antidepressants can have a very, very strong effect on libido in itself. So, multifactorial libido, not the easiest to tackle, but we do know that as you go through the menopause, there are some significant changes that contribute to it. And we do say that the better we feel, the more sexual we will feel. And that's absolutely true. Okay. So how common is it then? Well, up to 50% of women going through the menopause will report a loss of sex drive. So it's extremely common. Other statistics have shown that 1 in 3 young women will have some sexual problems. 1 in 2 older women will have sexual problems. So it's a common problem that is faced by women. We've seen this slide a few times, and I'm not going to go through all the options for treating menopause in detail today because we had a different workshop on that. However, we know that anything that will help with your menopausal symptoms will help you to feel better and then could therefore improve your libido. So all of these options to treat your menopause could potentially improve your libido. However, don't underestimate lifestyle changes, so cutting smoking out, reducing alcohol, losing weight and exercise. This can have a huge impact on libido. So just lifestyle changes can make a big difference. But speaking in particular about the various treatment options for poor libido, we've got psychosexual counselling, which is your sex and relationship therapy. This is available on the NHS and privately and can really make a huge difference. Okay. And then, of course, if we think that the poor libido is driven by the hormonal changes, then replacing the hormones that your body is lacking can make a huge difference. So whether that is through systemic HRT, estrogen and progestogen, if you've got a womb. Some women who have HRT will then need testosterone, and we're going to talk about that in a moment. Or whether it is the estrogens to help with the vaginal dryness. This has a huge part to play in poor libido around the menopause. Okay, so let's talk about vaginal dryness, this fancy term genitourinary syndrome of the menopause. Is essentially the term that is used medically for vaginal dryness. 1 in 3 women going through the menopause will experience vaginal dryness, so it's really, really common. And so you might get itching, irritation, dryness, pain, burning. The vagina becomes less elastic. It might even shorten. And the combination of all of that can make sexual intercourse more painful. You're also more likely to get infections, so waterwork infections, or even thrush and other sort of infections down there. And even in the absence of infections, you're likely to get sort of waterwork symptoms. So it might feel like your bladder is overactive, like you need to rush to the toilet, or you might leak. And it's all to do with the changes in the hormone levels there. So clearly, this doesn't sound very good, does it? If you've got these symptoms, it's clearly going to affect your libido. Okay, so it's very easily treatable, is what I would say. Vaginal estrogens are very safe. Even breast cancer survivors, on the whole, can have them. But I would say if you fit into that category, then speak to your healthcare professional. There are lots of different options. And I know I've shown you this before in a different workshop, but I thought I'll show you again. So you can have a pessary. So something like this is Vagifem, or a reusable applicator is called Vagirux. And you can even buy this from the chemist as the product called Gina. So it's a pessary that you put into your vagina and it releases estrogen locally there, and it replenishes the estrogen that you need and tackles those symptoms. We've also got a cream called a Vestin cream. I believe that brand name is now being changed. So you can use that cream vaginally. You can also rub it into the vulva and the opening of the waterworks, and it can really help with all of these symptoms, including overactive bladder. You've got low dose options. So specifically, I tend to use BSL as a gel, and Vagis is this kind of waxy pellet. I am inclined to use these more so in sort of breast cancer survivors, but it's an option for everyone. You've got this sort of really soft, flexible, bendy ring, which basically just sits in the vagina, lasts for 3 months, releasing hormone locally. It's quite popular, although in and out of stock. And there are other options for more severe cases. So you can use that in addition to HRT or in place of HRT. And generally speaking, it's really quite safe because you absorb very little into your bloodstream. So you can use vaginal estrogens in addition to non-hormonal treatments. So you've got vaginal lubricants and moisturizers. I've got some samples here today that you can take again, but the Yes range is excellent. You've got Replens, Silk, lots of different options. They're non-hormonal, which you can use by themselves, or you can use in addition to vaginal estrogen. And these can really help with the symptoms that we described earlier. Okay, so what about testosterone we spoke about before? Well, we know that the female body does rely on testosterone, and that comes as a shock to a lot of women. It's not just estrogen that we need, we do need testosterone. And testosterone is produced from the ovaries and from the adrenal glands that sit just above the kidneys. It's thought to be important in libido, sexual arousal, and orgasm, but we think that testosterone can also help with metabolism, muscle and bone strength, cognition. Okay, but at the moment, our research only really supports the use in poor libido, or this term, hypoactive sexual desire disorder. It's especially relevant if you have your ovaries removed surgically. You have half of your testosterone is suddenly removed, and you're more likely to feel the symptoms of lack of testosterone then. But essentially, our guidelines, they support the use of testosterone if you're already on HRT, but you still have a poor libido. And often just replacing HRT, just replacing that estrogen can really help with libido. But if it doesn't, then actually we can add in some testosterone. I've got a few examples here. So I've shown you this before, but Testim is a form of it. And then Testogel is another one. There's one that's also a pump called Tostran. So these are unlicensed preparations. And the reason why they're unlicensed is because they are male products that we use at lower dosages to maintain the female range. So at the moment, we don't have a product that's licensed for women on the NHS, but there is one privately, but not on the NHS. Okay. So it can help in some women with libido, but obviously we spoke about how libido is so multifactorial that it's just worth noting it is not a magic cure, but it can help in some scenarios. Okay, so how can your partners help? Showing interest, showing support by reading about the menopause and sort of going through that journey together. Being patient is really important. Anything that will help that woman feel better in herself. Boosting confidence, self-esteem, anything that's romantic, date nights, or even just helping support lifestyle changes. So support in exercise and doing it together, or supporting each other in losing weight or a healthy lifestyle. But certainly communication is the key here. And I know it can be really tricky, but there are things that can help from a partner's perspective that can help that woman feel better in herself and then improve her libido.